my great pleasure presenting to you my lecture on the practical recommendations in major depressive disorder management. My name is Siegfried Kasper. I'm the Professor Emeritus and former Chair of the Department of Psychiatry and Psychotherapy, right now working at the Center for Brain Research at the Medical University of Vienna in Austria. Before I start, I would like to give you my potential conflicts of interest, including also manufacturer who manufacture new medication like Janssen Pharmaceutical. When you look in your practice, and this is a picture, as a matter of fact, from Germany, and you see there are a number of patients with depression, but on the other hand, in the reddish color, you see there is a substantial number of patients suffering from treatment-resistant depression. Like on this picture, it would be approximately 1/3 of the patients. We need an effective treatment for these patients, and treatment-resistant is defined that patients who did not respond to 2 lines of medication, like either monotherapy with SSRIs or SNRIs, then with the add-on or switch approach, and then 1/3 of the patients become treatment resistant. For this, it's quite important to have a new research line to be studied, what we did in Vienna in our patient group. The outline of my presentation would be the clinical consensus, which I put together with colleagues, then the administration technicalities, then the requirement for the clinic, and then fourth, practical questions frequently raised. Let's start with the clinical consensus. Together with colleagues from Poland, Italy, Spain, Belgium, and also UK, we sat together like approximately 1 year ago to talk about the practical recommendations, which I give you the highlights right now. And the highlight is, from my point of view, the treatment algorithm, that patients were treated first line with adequate medication, then you increase the dosage. If there is no adequate response, then you go to the next antidepressant. You either augment this medication or you switch to another medication. If this does not work, then again augmentation, combination or switching could take place, or then the new esketamine intranasal application together with SSRIs or SNRI. Please keep in mind what you see on the bottom line of this graph here, that psychotherapy and non-pharmacological therapies like ECT, TMS may be considered at any point during the treatment pathway. The contents of this treatment recommendation is to understand the different facets of TRD, that treatment-resistant depression is a complex, multifaceted disorder with distinct neurobiological, genetic, and clinical psychosocial factors. And then is the consideration prior to initiating treatment with esketamine nasal spray, and then finally the practicalities of esketamine nasal spray administration. All these points will be covered, and I will speak in my presentation also to these points. The first point, who are these patients with treatment-resistant depression? Who is at risk for this treatment-resistant? In our large database, we came out with a so-called machine learning approach, which takes care of all the different factors, and the factors: symptom severity, suicidal risk, higher number of lifetime depressive episodes, comorbid anxiety disorder were the prominent risk factors, and further risk factors if the patients suffer from psychotic symptoms, higher numbers of previous antidepressants, or a longer duration of current episodes, and inpatient status. These clinical factors are useful as predictors, and they are easily to be obtained also in clinical routine settings, so please think about these factors. I put together with a colleague who is right now working in Hong Kong on the suitability of medical analogies and we discussed that acute depression would be broken leg, and then the long-term treatment would be like hypertension. So treatment of depression is like treatment of hypertension. Let's have a look at the evolution of antidepressants. That's Ronald Kuhn, who firstly described imipramine quite a long time ago in 1957, and thereafter the tricyclics came, then the SSRIs came. There was a refinement in treatment with less side effects, but with a clear new mechanism of action is esketamine, which has been now approved by the American health authorities, FDA, and by the European counterpart, the EMA. We looked at different treatment strategies in unipolar depressed patients and what are the patients in Europe get now for treatment of depression. That's a pharmacoepidemiological cross-sectional multi-center study, and you see here that patients were prescribed medication additionally to antidepressants, in the first place benzodiazepines, which indicates that something should be happening on the GABA receptor, because otherwise doctors wouldn't give it to their patients. Then in the second part, antidepressants, so usually SSRIs and mirtazapine or SSRI plus trazodone. Then antipsychotics, that's like olanzapine, then aripiprazole or quetiapine. This number 24% includes inpatients as well as outpatients. If we only would include inpatients, this figure would go up to 50%. So these are the medication which patients get additionally to antidepressants, quite often when they are treatment resistant. The question emerges for augmentation therapy. Are second generation antipsychotics better than lithium or equal? In our large database, when we used the Montgomery-Åsberg rating scale or the Hamilton total score, the second generation antipsychotics, which were quetiapine, then aripiprazole and also olanzapine, were always significantly better than lithium. In another meta-analysis, we checked, well, what about augmentation with esketamine and compare it to second generation antipsychotics? We took the database which has been provided to the FDA when the second generation antipsychotics were introduced, and the database where esketamine was sent to the FDA, so it's an unbiased database, and here you see the outcome. The factor size is nearly double as large for esketamine compared to second generation antipsychotics. So if you take this data together, second generation antipsychotics are better than lithium, and the glutamatergic approach is better than second generation antipsychotics. This was also confirmed in a mega-analysis which was done by the Institute of Psychiatry in the UK by the colleagues from Alan Young, Professor Young, and they also came up that the NMDA antagonists have a high level of evidence to work beneficial for treatment-resistant depression, better than antipsychotics and better than mood stabilizers, which were predominantly lithium. What about the glutamatergic system? Animal research indicate if you stress the animal, then you have less synaptic connectivity. So the synaptic connectivity is thought to be connected to the glutamatergic system, and when you add then a glutamatergic compound, then you restore this mechanism. We firstly could show this in humans, in this case in healthy controls, when we gave esketamine infusions and compared to placebo, and we looked at the hippocampal structure. We could see already after 65 minutes an increase of this hippocampal function, which we think, according to the animal literature, might be linked to the synaptogenesis, what we could see in animal research. We also looked, does it affect the serotonin transporter? which would be, of course, of large interest because esketamine is given together with SSRIs or SNRIs. And in this PET measurement, we concluded that with the dosages which we use in humans, it does not affect the serotonin transporter. However, if we could go to higher dosages, like which is used in anesthesia, then it would affect also the serotonin transporter. So choosing the right treatment, I think it is important that treatment resistance can result from inadequate dosing and length of treatment. Then repeated inadequate drug trials may contribute to negative patient outcomes, and treatment decisions are based on guidelines, such as the WFSBP guidelines or the British guidelines, or to some extent also from the American guidelines. When we come to Spravato, the intranasal spray, I think it's quite important to be reminded on the indication for treatment-resistant depression. It has been indicated as a combination with the SSRI or SNRI in adults with treatment-resistant major depressive disorder who did not respond to at least 2 different treatments with antidepressants in a current moderate to severe depressive episode. What are the technicalities of administration and the requirement for the clinic? Well, you need a quiet room for pre- and post-administration monitoring. You need a chair where the patient can recline, and you need blood pressure monitoring equipment. So quite different to a usual psychiatric practice where you usually do not have the patient to lay down. It's delivered via nasal spray with the devices. One device has 28 milligrams. So when you give 2 devices, they come up to 56 milligrams. When you have 3 devices, 84 milligrams. And the patients play an active role in their treatment. So the nasal spray is self-administered under the direct supervision of the healthcare professional. Of course, this needs to be explained before. Then 1 spray in each nostril per device. Reclining the head to a 45-degree angle, and 1 to 3 devices depending on the dose, with a 5-minute rest in between. The patient should be observed with the healthcare professional during and after each administration. The blood pressure needs to be monitored, and the patient needs to be also monitored for sedation and dissociation following administration. The patient self-administers Spravato is in 5 key steps. For step 1, get ready. Step 2, prepare the device. Step 3, prepare the patient. Step 4, patient sprays once into each nostril. And step 5, confirm delivery and rest. And keep in mind the patient always should be also observed by the healthcare professional. The patients treated with Spravato should be observed and monitored, as I mentioned before. So the first advice would be to make travel arrangement to and from the appointment. So make sure that the patient has someone who picks him up. Then 2 hours before, no food. 1 hour before, no nasal corticosteroid or decongestants, and no drinks 30 minutes before. Then before the administration, the patient needs to confirm, like females, they are not pregnant, not breastfeeding, because it has not been studied in this indication, and there is no contraindication for Spravato for hypersensitivity, aneurysmal vascular disease, or the history of intracerebral hemorrhage. And then the pre-dose of blood pressure needs to be measured, and the general guide is 140 to 90 for patients below 65 years of age, and below 150 to 90 for patients above 65 years of age. Then by the healthcare professional needs to supervise 1 spray in each nostril. Second, monitor the blood pressure. Then monitor the dissociative and perceptive symptoms, and monitor the levels of sedation, and ensure the patient is in a clinical stable condition before the patient goes home. At the end of the monitoring period, which is usually 1 to 2 hours, use the checklist to determine whether the patient is ready to leave, confirm that there are no signs of dissociation, confirm that the patient is fully awake, no sedation, confirm that blood pressure is at acceptable levels, and ensure the patient has planned to travel home by public transport or a lift from someone else. The practical questions which are frequently raised are the following. So, what about the oral antidepressant use, the placebo effect, how Spravato differs from ketamine, how long to continue Spravato treatment, discontinuation in clinical trials, dissociation and its management, what about addiction and dependency? I will go through these points. Now, the oral antidepressant, it has been studied on top of SSRIs and SNRIs. So we do not know at this stage how this Spravato work with mirtazapine, for instance, has not been studied. This can be shown in future studies. And two distinct modes of action can work together to increase the likelihood of treatment success. Like with SSRIs or SNRI, you go to the serotonin or the norepinephrine transporter, and here you go to the glutamatergic system when you use Spravato. And the oral antidepressant therapy can help to maintain symptom improvement. What about the placebo effect? Of course, there is a placebo effect with all the treatments what we are doing. However, we know that in the studies, the esketamine was studied also compared to the placebo condition and showed significantly difference between the placebo and also the esketamine situation. So the factors which contribute to the placebo effect, they may include the travel to the clinic, trial center, the anticipation of different treatments, and having increased and regular trialist contact time. That should not be underestimated. Most importantly, there is the placebo-controlled studies which confirm its efficacy. How is Spravato different to IV ketamine? Altogether, since I did both treatments with my patients, the Spravato treatment is better accepted by the patients, has less side effects, and esketamine is 3 to 4 fold higher affinity for its target than the R-ketamine. So the higher potency allows to be used at lower dosages than the R-ketamine without compromising efficacy. Ketamine is approved for anesthesia and has not undergone rigorous assessment in mood disorders and has a comprehensive RMP in place, supporting safe and effective use in the real world. For me as a clinician, the most striking difference is that the patients have less side effects. It's better tolerated in these patients. What do we mean by dissociation? Dissociation is a symptom which we do not have until now with our medications which we use. It's a detachment from oneself, kind of depersonalization, and then it goes to the detachment from one's surroundings, kind of derealization. In the clinical trials with Spravato, 27% of the patients experienced dissociation, which were typically mild and most importantly transient. So like with SSRIs, when you have the gastrointestinal or sexual side effects, they are long-lasting, but here they are transient, which is most important. The management of the dissociation should be like, as I mentioned before, they are typically mild. Only 4% have severe dissociation side effects. The peak is around 40 minutes and typically resolve within 90 minutes. And the patient should be made aware that these symptoms can come up, and it's important to have a comfortable, calm environment, and advise the patient to focus on pleasant thoughts, probably, if the patient agrees, listen to music during administration. Usually no specific medication or intervention is required. The support, the assistance and reassurance that nothing bad is happening is usually the thing which needs to be done. What about sedation? In the studies, 9% had sedation, somnolence, like 18%, and they were also mild and moderate and transient. Quite importantly, they peaked at 40 minutes and resolved within 1 to 1.5 hours. And this patient needs to be aware before the administration of esketamine that this happens and does not need a specific treatment. The blood pressure increased, quite importantly also that the patient is monitored before the esketamine administration, that the blood pressure is not too high. It's again the peak like 40 minutes after initiation, and the duration is 1 to 2 hours. And we should be aware about the contraindications, that Spravato should not be given with aneurysmal vascular disease or a history of intracerebral hemorrhage or a recent cardiovascular event, including myocardial infarction. And if the patient has higher blood pressure, then a continuation with the medication is not advised before the patient has a stable blood pressure management. What about concomitant medication? So those medications who increase sedation, like benzodiazepines, well, alcohols and opioids, of course, the patient should not take before, and psychostimulants may increase blood pressure, like if the patient has modafinil or the methylphenidate. Then MAO inhibitors may also increase blood pressure, like if the patient is on trilacipramine, for instance, Seligine, varenicline, and this needs to be, of course, everything closely monitored for sedation or increased blood pressure. There was no evidence in the side effects related to abuse or misuse, and no evidence of withdrawal symptoms in clinical studies. This is quite important. One, for me as a clinician, very important point is that in the long-term studies, there was even a reduction of the medication, which is quite unusual for a medication which should have also abuse potential. Well, the medication should be given in a direct supervision of a healthcare professional. So it should not be given in a package to the patient and say, well, whenever you feel not good, take one of these nasal spray. Of course, then you have a patient who is addicted to the medication. So within this frame that the patient comes to the hospital or the treatment unit, it has been shown to be safe without the abuse and misuse property. A risk management plan for Spravato is in place, and this, as I mentioned before, the important identified risks are the dissociate states, the perception disorders, the disturbation in consciousness like sedation, and the blood pressure increased, and drug abuse. And we need to think about that this medication has not been studied during pregnancy, so it shouldn't be given to patients who are pregnant, and the patients when potential risk interstitial cystitis for long-term use in high dosages, which are not given in the patients with treatment of depression, has been reported when it was used for analgesia purposes, for instance. I mentioned already the contraindication for the treatment with Spravato, the hypersensitivity to the active substance ketamine, and patients for whom an increase in blood pressure or intracranial pressure poses a serious risk, like aneurysmal vascular disease, then history of intracerebral hemorrhage, or the cardiovascular recent event, including myocardial infarction. Some other populations in which caution is advised should be patients with a prior history of psychosis, mania or bipolar disorder. Of course, these patients need to have a mood stabilizer. Then hypothyroidism, when it's not sufficiently treated, a history of brain injury, hypertensive encephalopathy, or intrathecal therapy with ventricular shunts, or any other condition associated with increased intracranial pressure. The dosing and monitoring in special population, well, age is one of the special population. So age or those of Japanese ancestry, the initial Spravato dose is 28 milligrams, and the subsequent doses 28, 56, or 84 milligrams, and the dose changes should be in 28 milligram increments based on efficacy and tolerability. The patient with clinical and significant or unstable cardiovascular or respiratory conditions, they should be closely monitored and to be checked if the Spravato treatment should be given when it outweighs the risk for this medication. That would be a treatment model like the initiation of the esketamine in the induction phase, like 2 times per week for 4 weeks, then reduce the frequency of administration to once weekly for 4 weeks in the maintenance phase, and the continuation maintenance phase, then administration every 2 weeks or once weekly in the patient's population. Let me come to the end of my presentation and discuss with you a few case reports. One would be a female copywriter in her mid-30s, married. She has a 6-year-old son, has good family relationships in childhood. She's a high achiever, consistently top of the class, but put a lot of pressure on herself, often experienced low self-confidence and anxiety. The first episode of major depression emerged when she was 25 years old. It resolved from escitalopram treatment, and then experienced shorter depressive episodes for about 4 years until pregnancy, after which she was symptom-free for a longer period. Now a new episode emerged in 2019. She was treated with SSRIs and SNRI that led to short periods of minor improvement, but no full recovery. When she came to the office, she described sadness, anxiety, exhaustion, problems leaking, lack of motivation. So all these symptoms which you can see in major depressive disorders. She also felt guilty on her son's childhood that she could not be a good mother for him. This Spravato treatment started in combination with SSRIs, and there was already a substantial improvement after 2 weeks. And after 1 month, she was taking more family responsibility, responded to job opportunities, and after 2 months, she became working again as a part-time translator. That would be an ideal case of a patient which could not be treated with SSRI or SNRI alone. The second case would be a female in her early 50s with a recurrent major depressive illness, at least one episode every 2 to 3 years. During a recent episode, she has been particularly affected by symptomatic periods of very long duration with a very severe form of depression. There was a resistance to treatments in her last 3 episodes, at least 3 quarters, different treatments each time, and took at least 6 to 9 months to recover from each episode, despite multiple application of antidepressants. The last episode, patient didn't respond to duloxetine, didn't respond to paroxetine in good dosages. There was only a very marginal improvement. On top of paroxetine, Spravato has been studied, and she says, well, it's the first time since 10 years that I feel normal again. Then we decided, based on the rating scales, that she is remitted. The third patient is a male retired professor. He fell into a major melancholic depressive state when he has lasted for 2 years. He received multiple antidepressants with no effect. including combination and augmentation. He experienced a brief period of partial response, also following ECT, but thereafter he experienced a refractory depressive episode. He later received venlafaxine 300 milligram, although no good effect, switched to sertraline bupropion in combination. Interestingly, when we put him on Spravato, he experienced gradual and significant improvement after the third week and reported also about a sustained remission. So let me summarize the data which I presented to you and the practicalities. I think it's easy to set up, but it's different set up than with SSRI or SNRI treatment. It's also easy to scale up, meaning that you have to give another 28 milligram device to the nostril applied by the patients. It's generally well tolerated. There are some side effects which are reported to you, which the patient needs to know, and when the patient knows them, usually the side effects are not that bad. And the Spravato treatment shows a high effectiveness in real life and in early prescriptions. Altogether, when I talk to my colleagues, 70% effectiveness in our patients, which is quite good in this population group, which did not respond, as I showed you before, to different other medication. With this, I thank you very much for your attention. You see my email here. You see that we emerge on a new approach of the glutamatergic system when we use the new medication, which will, on top of the other medication, be for the benefit for our patient. Thank you very much.